Welcome to It's Your Case, presented by YST.com. I'm Christina Meerhof, your radiologist on demand for this week. Today's example is a 14-year-old female spayed Yorkshire Terrier with diarrhea and lethargy. Once you have reviewed the radiographs using your systematic approach, then you're ready to watch this video. Now I will highlight the most important findings for these radiographs. The intervertebral disc spaces T12-13 and 13L1 are narrowed and ventral spondylosis is present. Spondylosis is also present to a lesser degree in the lumbar spine and at the lumbosacral transition. L1 has one broad rib on the right side, a large space-occupying lesion with sharply delineated borders is extending from the abdomen into the area of the caudal esophagus in the midline. On the different projections, the lesion varies slightly in size. In the images in which the lesion is smaller, a gas-opaque rim dorsal to it, as well as mildly gas-filled stomach are present. There's the gas-filled rim and a small amount of gas still in the antrum. Only small parts of the stomach are visible in the images where the lesion is larger. So there's some part of the stomach seen here and there, and its contour is continuous with the soft tissue opaque lesion in the midline. We see this also in the other projection. So here is the soft tissue opaque lesion, which is partly superimposed with the diaphragm, and the remaining stomach is probably somewhere here. This could be antrum. The abdominal detail is good. Liver and spleen are within normal limits, so this is probably liver and spleen, and we see the spleen also in the VD view. Small intestines contain small to moderate amounts of gas with rather reduced signs of peristalsis there, so we do not see any contractions here. One small intestinal loop in the right mid-abdomen is severely gas dilated and leads towards the region of the cecum. So this intestinal loop has to be small intestine. A soft tissue opaque oval structure of about 1 centimeter diameter, surrounded by gas, is located in the right cranial abdomen. It is in close proximity to the dilated small intestinal loop and is partly superimposed with the colon. The descending colon contains a moderate amount of gas and the wall is partially corrugated. This is seen here in the VD projection. There are many small contractions and also in this lateral projection. So my conclusions for the radiographs are a segmental dilation of a small intestinal loop with questionable foreign material, a sliding hiatal hernia, an empty colon with signs for hyperperistalsis, a thoracolumbar transitional vertebra, and a chronic intervertebral disc disease at the level of TH12 to L1. The focally dilated small intestine could represent the terminal ileum. The structure superimposed with the right cranial abdomen could be located at the iliosacroiliac junction or already within the ascending colon. An ultrasound of the abdomen is recommended to exclude the mechanical ileus as a cause for the gastrointestinal signs of the patient. The corrugation of the colon is compatible with hyperperistalsis and the diarrhea of the patient. Sliding hiatal hernias are often incidental findings in patients with upper airway obstruction and the associated increased negative pressure in the thorax. Due to the breed, a tracheal collapse should be excluded, but hiatal hernias could also be of congenital origin. They do not represent surgical emergencies unless the stomach is incarcerated, which would lead to gas distension and therefore dyspnea and shock. Therefore, the patient should be monitored closely. Aspiration pneumonia is associated with hiatal hernias and should be considered in case the patient develops respiratory signs and fever. The significance of the other findings has to be evaluated clinically. Be sure to review the full report associated with this case. Thanks for listening, and remember, it's your case, so please post your questions on social media.